Good day, everyone. I'm Dr. Zote Chabon. I'll be discussing the chapter on esophagus. I encourage you to read more on the topic since I'll be tackling important points only. Thank you. The esophagus is a muscular tube that starts as the continuation of the pharynx and ends as the cardia of the stomach. Three normal areas of esophageal narrowing are evident on the barium esophagogram or during esophagoscopy. The uppermost narrowing is located at the entrance into the esophagus and is caused by the cricopharyngeal muscle. It is the narrowest point of the esophagus. The middle narrowing is due to an indentation of the anterior and left lateral esophageal wall caused by the crossing of the left main stem bronchus and aortic arch. The lowermost narrowing is at the hiatus of the diaphragm and is caused by the gastroesophageal sphincter mechanism. The cervical portion of the esophagus is approximately 5 cm long, the thoracic portion is 20 cm long, and the abdominal portion is 2 cm. Blood supply and innervation. The cervical portion of the esophagus receives its main blood supply from the inferior thyroid artery. The thoracic portion receives its blood supply from the bronchial arteries, with 75% of individuals having one right-sided and two left-sided branches. Two esophageal branches arise directly from the aorta. The abdominal portion of the esophagus receives its blood supply from the ascending branch of the left gastric artery and from inferior phrenic arteries. The parasympathetic innervation of the pharynx and esophagus is provided mainly the vagus nerves. The cricopharyngeal sphincter and the cervical portion of the esophagus receive branches from the both recurrent laryngeal nerves, which originate from the vagus nerves. Damage to these nerves interferes not only with the function of the vocal cords, but also with the function of the cricopharyngeal sphincter and the motility of the cervical esophagus, predisposing the individual to pulmonary aspiration. The lymphatics located in the submucosa of the esophagus are so dense and interconnected that they constitute a single plexus. There are more lymph vessels than blood capillaries in the submucosa. As a consequence of this non-segmental lymph drainage, a primary tumor can extend for considerate length superiorly or inferiorly in the submucosal plexus. Assessment of esophageal function. A thorough understanding of the patient's underlying anatomic and functional deficits before making therapeutic decisions is fundamental to the successful treatment of esophageal disease. The diagnostic tests as presently used may be divided into four broad groups. A. Test to detect structural abnormalities of the esophagus. B. Test to detect functional abnormalities of the esophagus. C. Test to detect increased esophageal exposure to gastric juice. And D. Test of duodenogastric function as they relate to esophageal disease. Here, I'll describe more on the test to detect structural abnormalities because it is more common, it's practical, and more applicable in our setting. Barium swallow. Barium swallow evaluation is undertaken selectively to assess anatomy and motility. To detect lower esophageal narrowing such as rings and strictures, fully distended views of the esophagogastric regions are crucial. The density of the barium used to study the esophagus can potentially affect the accuracy of the examination. Esophageal disorders shown clearly by a full column technique include circumferential carcinomas, peptic strictures, large esophageal ulcers, and hiatal hernias. The radiographic assessment of the esophagus is not complete unless the entire stomach and the duodenum have been examined. A gastric or duodenal ulcer partially obstructing gastric neoplasm or scarred duodenum and pylorus may contribute significantly to symptoms otherwise attributable to an esophageal abnormality. When a patient's complaints include dysphagia and no obstructing lesion is seen on the barium swallow, it is useful to have the patient swallow a barium impregnated marshmallow. a barium-soaked piece of bread, or a hamburger mixed with barium. These tests may bring out a functional disturbance in esophageal transport that can be missed when liquid barium is used. Endoscopic evaluation. The first diagnostic test in patients with suspected esophageal disease is usually upper gastrointestinal endoscopy. This allows assessment and biopsy of the mucosa of the stomach and the esophagus, as well as the diagnosis and assessment of obstructing lesions in the upper gastrointestinal tract. In any patient complaining of dysphagia, esophagoscopy is indicated even in the face of a normal radiographic study. Example is esophagitis and Barrett's esophagus, as they are complications of gastroesophageal reflux disease or GERD. For the initial endoscopic assessment, the flexible fiber optic esophagoscope is an instrument of choice because of its technical ease, patient's acceptance, and the ability to simultaneously assess the stomach and duodenum. The rigid endoscopy is now only rarely required, mainly for the disimpaction of difficult foreign bodies impacted in the esophagus, and few individuals now have the skill set and experience to use this equipment. Esophagitis LA grading system. When GERD is a suspected diagnosis, particular attention should be paid to detecting the presence of esophagitis and Barrett's columnar lying esophagus. The commonest system now in use is the Los Angeles grading system for esophagitis. In this system, mild esophagitis is classified LA grade A or B, one or more erosions limited to the mucosal folds, and either less than or greater than 5 mm in longitudinal extent respectively. More severe esophagitis is classified LA grade C or D. In grade C, erosions extend over the mucosal folds but over less than 3/4 of the esophageal circumference. In grade D, confluent erosions extend across more than 3/4 of the esophageal circumference. In addition to these grades, more severe damage can lead to the formation of a stricture. A stricture's severity can be assessed by the ease of passing a standard endoscope. When a stricture is observed, the severity of the esophagitis above it should be recorded. The absence of esophagitis above a stricture suggests the possibility of a chemical-induced injury or a neoplasm as a cause. The latter should always be considered and is ruled out only by evaluation of a tissue biopsy of adequate size. It should be remembered that gastroesophageal reflux is not always associated with visible mucosal abnormalities, and patients can experience significant reflux symptoms despite an apparently normal endoscopy examination. In the image shown, these complications of reflux disease as seen on endoscopy. Image A, linear erosions of LA grade B esophagitis. On image B, uncomplicated Barrett's mucosa. Image C, high-grade dysplasia in Barrett's mucosa. And picture D, early adenocarcinoma arising in Barrett's mucosa. Gastroesophageal reflux disease, or GERD, has grown to be a very common problem and now accounts for a majority of esophageal pathology. It is recognized as a chronic disease, and when medical therapy is required, it is often lifelong treatment. It is believed that GERD has its origins within the stomach. Distension of the fundus occurs because of overeating and delayed gastric emptying, secondary to a high-fat diet. The resultant distension causes unrolling of the sphincter by the expanding fundus, and this subsequently exposes the squamous epithelium in the region of the distal lower esophageal sphincter to gastric juice. Repeated exposure results in the inflammation and the development of columnar epithelium at the cardia. This is the initial step of the development of carditis and explains why in early disease, esophagitis is mild and commonly limited to the very distal aspect of the esophagus. The development of carditis explains the complaint of epigastric pain often experienced by patients with early reflux disease. Additionally, This process can lead to a fibrotic mucosal ring located at the squamocolumnar junction, which is termed a Sachski ring, and which may result in dysphagia. This inflammatory process may extend into muscular dystrophy and thus result in a progressive loss in the length and pressure of the lower esophageal sphincter or the LES. This explanation for the pathophysiology of GERD is supported by the observation that severe esophagitis is almost always associated with a defective LES. Once the diagnosis is established, treatment will be initiated with either PPI therapy or anti-reflux surgery. First-line therapy entails anti-secretory medication, usually PPIs, in most patients. Failure of medication to adequately control GERD symptoms suggests either that the patient may have relatively severe disease or a non-GERD cause for his or her symptoms. Endoscopic examination at this stage of the patient's evaluation is recommended and will provide the opportunity to assess the degree of mucosal injury and the presence of Barrett's esophagus. High-dosage regimens of hydrogen potassium PPIs, such as omeprazole, that's up to 40 milligrams per day, can reduce gastric acidity by as much as 80% to 90%. Unfortunately, within 6 months of discontinuation of any form of medical therapy for GERD, 80% of patients have a recurrence of symptoms, and 40% of individuals with daily GERD eventually develop symptoms. Once initiated, most patients with GERD will require lifelong treatment with PPIs, both to relieve symptoms and to control any coexistent esophagitis or stricture.